Good morning, everyone. Welcome to our 10th webinar of 2021. It's a whole new world, care planning during the transition to congregate services. As I think you know by now, I'm Lydia Missalidis, your host for these webinars. We have a little over 400 people registered, and last I looked, people were still logging on. So welcome to all of you. We've got providers, allies, managed care partners, and state partners joining us today. So a huge welcome to all of you. These twice monthly webinars, as always, are made possible by a grant from the Archstone Foundation. So we are appreciative of their support. Next. As always, this webinar is being recorded, and it will be accessible from the CADS website, either later today or tomorrow morning, I would say. Our format is listen only. You will have received an email from Pam at the CADS office this morning with the PowerPoint and 4 attachments. The handouts tab on GoToWebinar is not working today for some reason, so please be sure to check your email if you want to access those handouts. They do include samples of care plans that we'll be talking about today. We do encourage you to submit your questions and comments in the question box on the control panel, and it's really helpful for us with 6 panelists and myself if you would identify who the question is directed to, if it is directed to one of the panelists or to me. I can't promise we're going to get to all of your questions live or be able to answer them, but we'll do our very, very best today. Audience chat and hand raise features are off. Staff can send chat messages out to all of you, so if you see a chat message pop up, please check that out. And very last of all, but not least, we do value your feedback and ideas, so please take 5 minutes or less to complete the survey at the end of the webinar. We read every single one of your comments each week. Next. Last webinar topic was called A Deep Dive into All Center Letter 21-07, Strategic Planning for Your Phased Return to Congregate Services. Terrific conversation with our panelists again and Department of Aging. You can see a sampling of their evaluation comments here. For many of you, I think we had more than 50 comments. And this is just a sampling of those. So again, everyone really appreciated that conversation, and we appreciate your listening in. Next. Some of you may have attended Department of Aging's question and answer session. I think it was 2 weeks ago, to discuss anything that was on your mind related to that ACL. And I do want to take this moment to thank the Vision team members and Department of Aging for that assist for all of you. Jill Sparrow from Department of Aging CBAS unit asked me to let you know that a frequently asked questions document, an all center letter, will be coming out soon, so please watch for that. For today's agenda, we're going to review what adult day programs who are licensed through the Department of Social Services and adult day healthcare CBAS programs that are licensed through the Department of Public Health and certified through the Department of Aging, what they're all doing to fully engage with participants and caregivers to support reentry to congregate services. You're going to hear from our panel members what they're working on now, what they're keeping at top of mind for their near and longer term strategic planning and activities. And then we'll review the basics of care planning, especially for those of you who may be new to our field, and then dig deeper into how to think about care planning for hybrid services. That is what we're allowed to do now, which is a combination of congregate services and temporary alternative services to meet people's needs in a person-centered way. So our panel members have offered to you some sample care plans that they've been developing using different approaches, and yet they're all applying the same care planning principles that we'll hear about today. And again, you can find those in your handouts, and also included in the handouts is a very nice 2-page mitigation plan from Terry Whitmire, who's one of our panelists today. She's an adult day program leader in our community and has been for 40 years now. Next. So here are our panelists. Lana Harutunian, MSW Program Director at New Sunrise in LA. Kay Lee, MPH Vice President Commonwealth in Orange County. Richard Lee, Program Director Beverly, ADHC in LA. Amanda Sillers, LCSW Administrator, Santa Maria Wisdom Center in Santa Maria. Terry Whitmire is MSW and LVN Program Administrator at Adventist Health Lodi Memorial Hospital, and she's an adult day program, as is Reina Zavala, Program Director, Adult Day Services South, El Centro, Easter Seals, Southern California, also an ADP serving primarily people with intellectual and developmental disabilities. So thank you to our panelists today. We're looking forward to a really exciting discussion. Next. So we're using our ready set reminder. We're still in ready phase. Some of you might be close to set. What we're thinking that set is sort of a soft opening, if you will, as you begin to slowly bring people in, check how things are going with your staff, with transportation, with scheduling, and getting your feet wet again as you get back to more fully congregate services over the next number of months. Next. So big news of the week, of course. I think all of you have been following this, but here's a little reminder. Updated CDC guidance just came out last week. It eases mask wearing for fully vaccinated people indoors and out. I've already been getting questions about this. We've talked about it with the Vision team. It is clear that this is intended for the general public in public places. It does not change California's mask order, mandated mask order, until we believe June 15th, when the governor will announce that the tier system has been abandoned and the state will be fully reopened. So that is still the target date for reopening and for complying with the CDC masking order. In that masking order, if you look at it carefully, everyone, you can see that it does not apply to healthcare settings. They are excluded. So for us, that means that we have to continue using distancing, masking, and hand hygiene as we await further instructions from the state. And the Vision team is going to make another attempt to see if we can get our California Department of Public Health to help us with some guidance specific to our congregate setting. We do have some recommendations for them, and we'll take another run at that in the next few days or so. So stay tuned, everyone. In the meantime, please continue to follow California masking and distancing rules. Next. So today we're combining our adult day programs with our ADHC CBAS providers. And this is just a little chart to show you some differences and similarities between the two program types. For example, adult day programs were never ordered to stop congregate services, although many did. Many now are starting to recongregate. They have a number of guidance papers, and I'll talk to you at the very end of this webinar about a conference call that Department of Social Services is hosting. And CBAS, ADHC, of course, have guidance from the Department of Aging. They were required to decongregate. We're getting back now to congregate services. Adult day programs are going to start seeing surveys starting May 10th, and CDA is estimated to start around September 15th, last we heard. Next. And in summary, basically, I just wanted to say again that we're still in a public health emergency. Both provider types can provide services in alternative ways, in person, in center, and using other service modalities. We don't know when the public health emergency will be lifted, but in the meantime, we are here to support you moving to a hybrid model of care, and I know everyone is very excited about that. So with that, I'm going to next turn our presentation over to Kay, and we're going to go through some highlighted areas of concern that will give you guys a little bit of a marker as to where we think generally people need to be during May and June. So Kay, welcome and thank you.
Thank you, Lydia. Good morning, everybody. Again, my name is Kay, and I'm from Commonwealth Adult Day Healthcare Center in Buena Park in Orange County. And I'm going to be talking to you a little bit about some staffing considerations. Next slide, please. So personnel. So as we go through this ready, set, and even the go periods, personnel and your staffing is really essential to the success of developing and implementing your hybrid program. So these are just some considerations that we felt are important into ensuring the success of your program and bringing together all of your personnel. The first is to onboard and orient any newly hired staff. With the pandemic, there's been a lot of upheaval and change with staffing, whether it's because of other obligations or other considerations. Many centers have brought on new staff. And so what's vital is to ensure that all of your training and for your new staff is up to date, and that your new staff feel that they're trained and ready to not only continue with the remote services portion of tasks, but also to transition into this hybrid and eventually the fully congregate program that CBAS ADHC has been. And this goes for not just new staff, but also for current staff who have been here throughout the program, even before the pandemic began. It's always a good idea to update and to refresh any prior trainings and prior awareness of your program logistics and how things can run smoothly, or even more smoothly based on what experiences you gleaned over the task period. Next is to deploy familiar systems for documentation. We call this moving closer to usual work methods and tools. So while the pandemic and TAS has really enabled us to do things a little bit more creatively and change some workflows and to allow us to meet our participants where they are and to fully address their needs in the midst of a global pandemic, this hybrid period really provides the opportunity to transition more closely into regular workflow, whether it's bringing staff back to the center and getting their offices prepped for them to be working more full-time on site versus remotely at home, or if it's just getting your documentation ready, reevaluating whether it's time to change up your documentation to reflect a more congregate setting of services. Next is, again, to prepare staff to return for in-center work if staff are working remotely. As I mentioned, this may involve cleaning offices, updating desktops, updating computer systems, and even making sure that you have plenty of supplies and PPE for staff that are available on site for them to use, so that they feel safe and prepared to work at the center as we all transition into a congregate setting. And so staff will be needing to come back into the center if they were not doing so before. And finally, to again look through any existing policies and procedures that you have, both reflective of any changes that you made to ensure that your center is safe for your staff and your participants, as well as other just pre-existing personnel policies that have always been in place for a workplace. And CADS also has resources to help you make these crucial personnel decisions. There'll be a CADS hosting. CADS will be hosting a employment webinar next Monday on the 24th at 10:30. So if you have any questions, please contact CADS to enroll into that webinar and get some more information and some additional resources, and making sure that your staff are fully ready to go to welcome the participants back into a congregate setting. Next, I'm going to pass it over to Lena.
Thank you, Kay. My name is Lena. Hi, everyone. Good morning. I'm the program director at New Sunrise Adult Day Healthcare Center. And to continue what Kay was saying, speaking with participants, making sure that you are clear with your communication with your participants. And this ties in with being clear and including your staff when planning coming back to in-center services, because they are your point of contact with the participants. So making sure that the staff has a clear understanding so that they can relay that message to their participants and the families during the routine calls. You don't want to leave any surprises for the participants. You want to share your efforts as we transition to in-center services, and you want to allow them to be part of that process. Ask them what is it that they are the readiness to return to in-center services. What are some of the concerns that they have? And you want to share fact sheets that you can get from the CDC, LA County Public Health, to kind of back what you have been doing as you prepare for in-center services. I'd like to include those things, for example, in our weekly wellness packets that we send to the participants to show that we are following the CDC guidelines, the LA County Public Health guidelines, and just to ease their minds that we are aware of the restrictions as they are being lifted or the restrictions that are being in place, so that they know that we have their best interests as we move forward. One thing I want to mention is maintaining records of vaccination status, especially for newly admitted participants. One thing that I had to tell our team members is, when you are doing initial assessments, make sure you're asking about the vaccination status so that we have that on file as we admit new patients. With the participants who were with us before, we helped them through that process. We have that information. But as you newly admit them, that's something that you want to make sure you're asking so that you have that on record. I would like to pass this next slide on to Richard to speak about the facility.
Thanks, Elena. Hi, everybody. My name is Richard from Beverly Adult Day Healthcare. I'm going to be talking about the facility and space. I think everybody has started to at least conceptualize their space and see that it's probably their biggest limiting factor in terms of capacity and the ability to return to 100% congregation in the future. And so these are the kind of concepts that we want to reiterate, and kind of what Lena and Kay were talking about as well, kind of mull over and make sure that we have streamlined for the recongregation that is coming up ahead. I think we want to base our program on universal and what I would consider conservative truths, regardless of what tier or restrictions we have in place. And the main reason for that is that we're going to have changing masking mandates and kind of distancing mandates in the coming weeks and months. And so if we, develop our program and we set it to a certain standard right now with what currently exists, it's no longer going to be relevant in the future. So having that flexibility and making sure that we're pinning down items that we can for sure say that are not going to change is kind of an important concept at this point. And that includes things like the HVAC system, the things like sanitation, and things that we will continue to be doing in the future, even with the changes. Just paying attention to your state, city, and local Cal OSHA requirements, and knowing that, like what Lydia said in the previous slides, that the CDC guidelines don't necessarily apply to us because we're in a healthcare setting, and knowing that we have to take the conservative approach because we're dealing with the most vulnerable population. And so I would hope and encourage all the providers to just take a more conservative approach and the universal truths approach, and kind of pin down things that we have been doing and that we will be doing in the future. This includes wearing face coverings, maintaining 6 feet, even within transportation at this point. And going back to the idea of soft openings, I think it's starting at a lower capacity than we would want to be at this point because of all these things kind of interplaying among each other. Staggering start and departure times. I think if we want to have participants coming inside the facility for in-center services congregation, we want to make sure that, or it's just not going to be possible to have everybody come at once and leave at once. And so, throttling that by nature or, by necessity, I think is a really important point. And it gives us flexibility because we don't have to stick to the 4 hours time period for the program in itself. So having that flexibility is important. And so small things like that staggering is really important. Again, with the facility, improving ventilation, I think these are all things that we're really thinking about, and we know that will not change because these are kind of the new normals that we experience. And with that, I'd like to turn it over to Amanda for the transportation section. I think Amanda might, oh, okay, there she is.
Hi, everybody. I'm Amanda. I'm with Santa Maria Wisdom Center. And I wanted to talk a little bit about transportation and the challenges that we've gone through, and some of the thoughts that I've had as we've done this. So one of the challenges, of course, is how to get all the participants into the center and home and back home while keeping the participants 6 feet apart. The first thing that we did was we asked the families or the caregivers if they could, take the participants to the center and home. So we asked them to provide transportation if possible. We cut the number of days that participants can come to the center during the week. We, of course, let all of our participants and families know that if they wanted to come and were vaccinated, they could come at least one day a week. We tried this to see how it would work, and then we increased the number of days the participants could come to the center. So we really kind of got a full number of who was coming, who was ready to come, who wanted to come, who could come. Then from there, we developed a whole like a spreadsheet of who could come when and when were the best days for them to come. We started with one day because we wanted to make it easy and get that kind of settled, and then move to more days. At this point, our participants are coming pretty much no more than 2 days a week to the center. Like I said, it takes a lot of planning, and I'm going to go quickly through this. So it takes a lot of planning and time to figure it out and to schedule them. So just take your time and be really organized around this. We also combine the transport home with the food delivery to our participants as well. You can try running 2 out, another option to get, if you have a bigger center, we're not as that big. You can try running 2 2-hour shifts or 2 3-hour shifts in order to get everyone in the center at least one day a week who want to come and who you're ready to serve. The other piece is, of course, try to coordinate the food delivery with the transportation of the participants if possible, but always keeping in mind food temps and time in the vans. The physical van and transporting, we have in our policy and procedure that we've updated. We basically make sure that all the windows in the vans stay open between 2 to 4 inches. We have marked on the vans where people can sit. This saves time at our front door and also makes a lot of sense too. We don't want anybody on the van who has COVID or has COVID symptoms. So our drivers actually do the check prior to the participants getting on the van, and they would do both the questionnaire and they do a temperature check prior to them getting on the van. We have notified all the family members that if we find symptoms or issues with this, they will not be able to come to the center for that day, and we'll do follow-up later. And I think that's it. So next, I'm going to pass it over to Terry.
Hi, I'm Terry Whitmire. I'm the administrator for Adventist Health Loda Memorial Hospital Adult Day Services. You're going to hear music in the background because we are running our program. We opened up June 9th, or September 9th, pardon me, September 9th. We opened up slowly. We have a reopening plan. It's a mitigation plan that had to be approved by Department of Social Services, and you will be getting a copy of that plan. We sent that plan out to all of our family members before we opened up so that they knew what to expect as far as no visitors are allowed in our center, that we would be signing them in and out at the doorway, that everybody would be required to wear a mask, temperatures would be checked, symptoms would be asked. So staff and participants and their care providers have their temperature checked, and even a dial-a-ride driver has his temperature checked, and it is all documented. It needs to be documented for Department of Social Services that we have documented participants and staff temperatures. We have HEPA filters. We have opened some of our doors for filtering going back and forth. We started lower census, just kind of soft opening to see how it's going to work. I will tell you that with all of the wiping all touchable surfaces every 2 hours, constantly hand sanitizing, constantly reminding about putting masks on and making sure during meals our masks are secured and stored in a safe infection control manner, does take a lot of extra work and a lot of effort. We had quite a bit of training for the staff to do. Fortunately, being a hospital-based program, we do have infection control that could come over and give us that training. So that did help a lot. By February of this year, all of our participants, 100% of our participants and care providers have been vaccinated. We still are following the all masking guidelines. We follow hospital masking guidelines. When we're doing an assist in the bathroom, a close encounter assist, staff not only wear a mask, but they also wear a face shield. I mentioned a mitigation plan. The Department of Social Services requires a mitigation plan to be approved by your analyst. May 10th, they started doing in-person surveys based on the infection control domain that they have in their website. It will not be unannounced. They will call ahead of time and ask. A lot of the infection control domain is based on RCFEs because they also license those programs, but they will call you ahead of time and ask if you have anybody positive so that they know what kind of COVID positive, so they know what kind of PPE that they need to use. But it will not be unannounced. You'll know they're going to be coming in first. But we do need to be careful because if you go through the pins that the Department of Social Services sends out about weekly or 2 or 3 times a week regarding this inspection, some of the regulations that they're citing that they're going to be looking at refer to RCFEs, not to our regulations. So you need to be kind of proactive and pull out your regulation book when they come in, and if they try to cite you for a regulation, ask them to show it to you where it is in our regulations so they're not getting us confused. They still tend to do that, and we don't want to be cited on something that we don't have to pay attention to. They say that this is not, they're meant to be educational. It's not to cite us. They will cite somebody if they see some safety issues right off the bat. They will cite people, but generally most daycares are on site. They will start the full inspection on-site visit sometime late summer. 1st of September is what they have told us. But as I said, we're open and families are very, very grateful. We have some that are here 5 days a week, some are here just 1 or 2 days a week, and our census is starting to come up. We started with a census of 8 a day, and now we're up to about 12 to 14 a day. And people are calling to register as we speak. So with that, I will pass this on over to Lydia.
Thanks everyone for that summary of where we need to be at this moment in time. And Terry gave you a great overview of what's going on in her program. And so we're going to now ask each of you a question, which is, what are you most concerned about now and sort of top of mind, and what do you see as your next major activities over the next couple of months? So we'll go ahead and kick that off. And I don't have in front of me who we have going first on that.
I believe that's me, Reina Savada. How's it? Hi. I'm the program director for the Al Center Eastern Southern California, and what we're working right now is a combination of in-person and remote services, but we're pushing more into congregating, returning to the center. I'm very excited. This morning I received a call that we're probably going to be getting transportation by June 15, which means most of our individuals will be returning. Terry, I admire your work. You're doing really, really good over there. We got a slow start. We have individuals in person out in the community, but not at the site at this time. Our analyst has not yet approved our mitigation plan. We're in the works of it, but hopefully in the coming weeks we will get that mitigation plan approved, and we will have our individuals at site. Right now we are providing in person from their home to the community, 2 to 3 hours per day, Monday through Friday, and transportation is being provided by their care provider at this time. So we're looking forward to getting more individuals. And what we're doing right now for those in person is we pre-screen. We do pre-screen calls to ensure that the individual and the family are doing okay, that nobody's sick, and then we do check temperatures. We do also check temperatures of the associates, and we provide the services at our local community. The other thing that we are pushing on a lot is increasing the amount of hours that we are out in the community, and increasing the education vaccination on getting everybody immunized. Right now, we are at 95% of the individuals that we're serving already from our site being vaccinated, and 89% of our associates being vaccinated already. So we continued that education and helping them set the appointments, get to their appointments, in order for them to have more productive and active life in their community. And that's where we're at this moment. And I'm going to pass it on to Kay.
Thank you, Raina. So we're planning a lot of our in-person activities, our in-person program, and so it's kind of a twofold preparation process. We've gone through and we've done the cleaning, the spring cleaning and clear outs of our center, working with the HVAC systems, cleaning out the ducts, installing filters, all the fun stuff to get the facility itself ready to have our participants come back in a place where they can feel safe. And the second part of it, aside from the facility, is the planning with our staff. So we've been holding a lot of staff meetings and figuring out some of the best documentation practices, as well as the logistics of actually getting our participants to the center so we can start the evaluation and assessment process, which I won't go into because others will be able to explain it much better than I can. And so part of that is figuring out the transportation routes with all of the limitations that are in place with how many individuals can be in a vehicle at a time, pending any changes that come down, but we haven't seen just quite yet. So right now we are planning for a situation in which we have very limited number of people per vehicle, and so our routes will reflect that. And so right now, our process is getting the schedules set so that we can bring in a few participants at a time to get them started with the evaluation and assessment process and some of the programmatic elements at the center based on whatever their needs are evaluated as. And another point that I think, aside from the facility portion as well as the preparation with staff, is to be aware that this is a very fluid process. We've been emphasizing that we can make a plan, but sometimes it doesn't work out, and sometimes you have to do a 180 and rethink things. And so we're trying to use this time to plan for all the eventualities that we can plan for, whether it's a spike in cases, or if something changes with transportation, whether we can bring in more people at a time or less. We're trying to think of all of those eventualities, but recognizing that sometimes things may not work. For example, with documentation right now, we're planning to continue to complete our IPCs inclusive of boxes 13 and 14. But as far as the other documentation goes with progress notes and flow sheets, for example, we're thinking of sticking more to one type versus another based on what we think will happen right now. But once participants start coming in and we start evaluating and really double checking what we've been seeing this past year through tasks and remote services, we want to be able to stay flexible and change things on a dime if we need to. Next, I will pass it along to Lena.
Thank you, Kay. My gosh, we have come a long way. We have, our center started doing in-person reassessments at the center since April, and it is individual, so it's not congregate services. You don't need the 7027 approved in order to bring participants in on an individual basis. So we've been doing that since April, bringing participants into the center and completing the entire IPC along with boxes 13 and 14. Some participants have requested for the reassessments to be done at the home. So we did do in-person reassessments at the home of the participants. And one thing for those specific participants, we are also looking at, will they even be able to come back when we are fully back to in-center services. In addition, we've identified individuals who are not up for reassessment, who would need an evaluation because they would be coming back to in-center congregate services. And we would begin doing an evaluation for those participants and not a full reassessment since their TARs are not due. And we'll get into more detail. I'm a little bit ahead of myself, so we'll get into that later. As far as transportation goes, right now, the family members of the participants are able to assist with bringing in the participants individually to the center for the reassessments to be completed. And with hopes of new guidance, we can, and getting back to congregate services, getting our own transportation going as we once remembered having it. I believe, Richard, do you have more to add?
Sure. So our situation is a little bit different from Lena's because Lena has been bringing in participants since April because she had a prior plan approved to bring in-center participants. The center that I work at has not had that before, and so we have not seen any participants inside the center. What we have been doing is we've been doing doorstep deliveries and kind of assessments by our RNs and social workers going out into the field with the drivers when they're doing drop-offs every day. And so the bulk of the work of reassessing and kind of taking care of the evaluations is going to happen remotely for us. And that's just the way that it works best for our facility. Again, center by center, how we go through our evaluations, how we go through our assessments, it's going to be very different. And I think this panel discussion is just to highlight a little bit of the differences between the providers and how there are different ways of doing things. The next step for us is basically in July, we're going to start having participants coming in physically for congregate services through submission of the 7027. So prior to that, in the month of June, we're basically going to go through everybody and evaluate them to make sure that there are not significant changes or more things that we need to address within the care plan. For our facility, we have been, much like K-Center, inclusively doing the IPC and having updated H&Ps throughout the COVID process in the past year. And so we sit a little bit with more information that we can implement for the evaluations and assessments. But again, that's going to differ center by center. And so after we get through the evaluations in the month of June, we will have everybody basically screened and ready to go at the beginning of July to be able to at least once a week start bringing participants in and then start reassessing and doing the IPCs in conjunction with the TARs moving forward with the June reassessments as well. With that, I'll turn it over to Amanda to give her side.
Hi, so we actually started serving participants. As soon as we were serving a few a day kind of for respite kind of services before, not really congregate, but just bringing them in. Our participants, we have a real heavy dementia population. And so it was extremely hard this last year on the caregivers and of course on our participants. So, you know, my push the whole time, I was chomping at the bit to get our members back in the center and to provide those services because, you know, we just saw the deterioration that was going on and the absolute need for them to be in congregate. So as soon as the 7027 went out, boom, we submitted it pretty much immediately. Thankfully, I was on the call on the vision team calls prior, so I already knew what was expected, but I had already done a lot of kind of back work to make sure that our site was ready to go before, and we did a lot. So we have I call our site, it looks like a big old airplane hangar. So we are lucky that we have big doors on both ends of the building as well as going out to the patio. When we first started, we pretty much served everybody on the patio we tried doing, when we're doing just the respite kind of piece, we did most of our work out on the patio with probably about, I think our patio maxes out 6 feet distance with about 14 people. They were eating out on the patio mostly when we first started. We did make a choice to serve only people who are vaccinated in the center. That doesn't mean that we're not serving other people and that we're not continuing to provide services. We're just not providing the in-center services to people who are not vaccinated at this time. about, I'd say all of our staff except for one woman who works in the kitchen is not vaccinated. So all of our staff who work with our members are also vaccinated. So we set up all of our tables so they're 10 feet apart. They're 6 feet long tables, and so now we serve. I think we max out about 20 a day right now. Again, we're a small center. We have a small census. So I mean, we're a huge center, but we have a small census. So I already talked a little bit about transportation. We do major cleaning protocols. Every other stall is used. There's cleaning in the restroom. Only one person is allowed in the restroom at a time unless it's a caregiver that's supporting them in the restroom. We don't have more than one person in there at a time. We have different restrooms. We have a couple staff restrooms that we're using for the members as well as the regular restrooms. We do serve our members 4 hours a day. We decided to do that as well. So we've coordinated our transportation times with our dropping off food, which we prepare in our own kitchens. Let's see what else. I think that covers a lot of it. So one thing that worked really well that I like, and I'll talk a little bit more about this too, is that we did the evaluation. So as soon as we got the 7027 approved, we started our evaluations immediately, and that was our social worker activity coordinator and our nurse began doing the evaluations, and it was kind of a shortened form of the way we chose to do it. It was a shortened form of our regular assessment, and then we also had PTs also coming in to do these evaluations prior to the participants coming on a regular basis for congregate services. And we developed some hybrid care plans at this time. And what's really nice about that is as soon as, that means everybody who's coming in right now for services, their care plans have been updated to the hybrid. So because they're continuing to receive services at home and receiving services in the center. So it's extreme. One thing I just want to say too is be super flexible. It's complicated. It's hard. You're going to do things wrong. Accept that, and you've got have your tell your staff to be flexible and easy and gentle on themselves. We've all gone through a lot over this last year. It's been hard this whole period of time that now we're kind of moving into a change in our services. It's not what we used to have. It's not, and we've all been through quite a lot in this last year. So be gentle with yourself, be gentle with your center, be gentle with your staff, be super flexible. You've heard from 4 of us who are all doing it differently. It's okay to do it differently. Figure it out the best for you and for your staff and for your members, and just do the absolute best you can. Like that's my best advice, actually. And I'm sorry, I don't know who I'm supposed to be turning it over to next.
So Terry gave us a bit of a summary already of where she's at. Terry, anything you want to add to sort of what's your longer range thinking about bringing in additional participants?
We're hoping to start back up our transportation by July. I failed to mention that we're open, rather than the 8 hours, we're just open the 6 hours a day. By July, we're going to go back to our 8 hours a day. We had to make sure that we got a brand new physician's report for each one of our participants. But the families so desperately need this after being at home 24/7 with a dementia patient. They absolutely positively need our services, and they're very grateful for what we have, and they've been very good about doing what we've asked them to do. And our participants, the dementia patients, because they've been used to using a mask when they've been at home and are gone out to a store or whatever with their family, we've not had any issues. We have to gently remind them pretty much all the time, but they do it without a problem. So we're looking forward to getting our census back up to where we were pre-COVID, but I have a feeling that's going to probably be sometime late in the 3rd quarter.
Great, thank you, Terry. And I think you're one of the handful of centers that I'm aware of, there may be more now, that have 100% vaccinated participants and staff, true?
Yes, we are 100% vaccinated.
So congratulations on that. Okay, thank you, panelists. So we're going to move now to Richard with an overview of some of the key tasks that we all should be attentive to right now. And then we're going to dig into care planning and CBAS IPCs.
Sure, thanks, Lydia. We're going to set the stage a little bit more before we get into the actual care planning, because although care planning is really important kind of as a concept and with details, it's really important to see why we're care planning the way that we are. And so just to kind of set the stage with the different milestones that we have in front of us is really important. As you can see on the screen, we have April when the ACL 2104 was released, and that kind of had the guidelines of what we had to submit by the date of June 1st, and that includes the 7027, as well as the staffing form, the ADH0006. And so prior to June, we need to have that filled out. We have to have all our mitigation prevention in place so that we can start the recongregate process. Starting on June, that's when we have to start doing the reassessments fully with the MDT staff for the July starting TARS, and that's a requirement just moving forward. So in June, we'll be doing the July, and then the last people that we will be kind of handling in that timeline are the October reassessments, which would be the November TARS stating dates. That leaves us with the November reassessments that we don't cover within that period. So with the November reassessment participants, as well as the initial participants who may not have had the full MDT process through the past year, we will have to absorb them in the beginning period of June to October. And so a lot of providers have questions in terms of, okay, what about the participants that aren't covered between the June and the October? But these are the kind of programmatic kind of things that we have to figure out by each center and make sure that we do have at least evaluations for the participants before they are required to come into the center by October 31st. And again, October 31st is kind of the threshold that we think about right now that's concretely there. And that date is when all participants who are continuing with CBAS are going to be required to attend the center for in-center services at least one time a week. These dates are really important, and these are programmatic dates that we have been kind of set in stone by CDA. The other set of dates that are kind of in flux that we've been talking about for the first half of this the webinar was the dates of like the CDC and the masking, and those are kind of fluctuating as well. So we want to make sure that we dovetail those and make sure that we kind of pay attention to both those sets of dates. And so I think this is a really easy way for us to see. Next slide, please. Right now in May and June, I think this is the period where everybody really concretely lays down their framework for returning to congregate services. Everybody should be submitting their 7027s, having staffing ramp up so that beginning of June, we can have the regular reassessment process. With this reassessment process, we're going to make sure that we have what are called basically hybrid care plans. And by that, we are talking about the care plans that we have in place so that we can identify the problems, interventions, and goals that we're going to be doing in center, and also the ones for the people that we're going to be serving through task modalities, which are going to continue. So when we talk about hybrid, I think that's what we're really trying to convey, that there's actually going to be two methods of doing things, in center as well as remotely. And so having care plans that really evidence and justify the care that we're giving and the problems that exist and how we're going to take care of them is really, really important. The strategic planning, always really important. The strategic planning is really more about how providers are going to do things in addition to what we're going to do. I think we all know pretty much what we need to do, but the how is the really important part right now because of this kind of transient, intermittent, transitional phase that we find ourselves in, doing both tasks and congregate services through this interim period. Again, staffing is really important, as we went through before. The consultants, starting with the junior assessments, are all going to need their assessments to do the full IPC as required. And the evaluations, which don't replace the care planning process, which is part of it, and they don't replace the assessments that are going to be done for the new rolling TARS, but the evaluations to make sure that the people are appropriately coming back to the center is really, really important. And the last point on this slide is just really about the vaccination education and support for staff and participants. It's great that there are facilities that have 100% staff and participant vaccination, but including our facility, we don't have 100% yet. So striving for that will make sure that we have continued education and continued support and not to let up on that process. Next slide, please. And the last thing is kind of Amanda touched on it, the opportunity to try new ideas. I think rarely do CVAS facilities and adult day providers have the opportunity to really revamp the way that we do things. And so we really like to frame this as an opportunity to really overhaul how we do our documentation and how we care plan in the ways that we're gonna kind of go through in the next few slides. Really use this as an opportunity to improve and adapt. And kind of for our situation, it's kind of getting rid of the archaic care plan structure that may have outlived its usefulness in the past. We have been using the same IPCs for the same past 10 years in terms of structure. Obviously, the content is person-centered, but this might be a really good time for us to really rethink the way that we're doing care plans in the way that best serves our operation throughout this period. And so it's okay to try something new and adjust as needed. I think everybody accepts, including CDA and the providers, that this is going to be a very fluid process. And so making sure that obviously the precautions and the necessary steps are in place, but trying something new is definitely not advised against, right? It's something that's encouraged at this point. So making sure that these adjustments are made and that so that we can bring our participants back into the center safely and in the best way possible to leave that kind of cookie crumb trail of evidence and documentation that's going to be required that we're going to develop through the care plans. And with that, we're going to send it off to Lena once again, just to kind of continue this on.
Thank you, Richard. All right, so we want to make sure that we have, we should have already started bringing the MDT back in and training and educating on the reassessment process and the MDT process as we move forward under the task model. So that includes the RN, social worker, the OT, PT, activity, etc., and training and their awareness of the reassessment process, the completion of the entire IPC. This includes boxes 13 and 14 and boxes 15 and 16 as needed. You should have an idea about how your center will be going about conducting the reassessment starting next month. Not to stress anybody out, but we do have a week and a half left until June. And in order to meet the requirement of submitting TARs that are due July 1st, you do need to begin next month. And so, again, making sure that there's a training on how you will be using boxes 13 and 14, the wording that relates to hybrid care planning, and boxes in 15 and 16. And you will see some numerous examples, different examples from centers on how we have come up with hybrid care plans. Next slide, please. When it comes to care planning, no matter where we are providing the service, the care plan cycle remains consistent. So assessing the needs of the participant, meeting them where they are at the moment of assessment, creating an intervention and identifying who will be carrying out that intervention, and implementing a care plan and setting a goal and assisting the family, the participants in meeting that goal, evaluating your results, and making adjustments as needed. Next slide, please. So here we are with hybrid care planning. As I said before, we are still operating under the task model. TASK now includes in-center congregate services as well as remote services. And this is where the evaluation and the reassessment process comes into place so that we can figure out where the participant needs the services to be provided. Ideally, we are hoping to move participants back to in-center congregate services, but there will be participants who will continue to require needing the services at home. Beginning July 1st, as we said, all IPCs being submitted should be updated completely. This includes boxes 13 and 14, as well as 15 and 16. IPCs need to highlight the services being provided to participants in these different settings. For example, are the services being provided in the center, or are the services being provided in the home? What services are providing where? Who will be doing the interventions? What will the frequency be? And how you choose to document and write the care plans is up to each center. We will share different examples as we go through it. But again, one thing to remember is that this is temporary. This is as we transition back in, just as the beginning of the public health emergency, things will continue to change and we will adjust as needed. So you might start off one way and then decide, no, this is not working, and change it up to fit your center's needs, your participants' needs. Next slide, please. Care plans during hybrid services. Resume using, again, boxes 13 and 14 for the care plans. And like I said before, we will be sharing good examples from different centers on how we went about writing the care plans to meet the needs of hybrid services. And again, you will see that the care plans that we share will reflect in-center and remote services. We just have a different way of wording it, different way of putting it together. And we want to make sure that the managed care plans and CDA can easily identify which services are being provided where as we move forward with hybrid care planning. Next slide, please. Evaluation and assessment. I know that this has been an ongoing conversation. What is evaluation? What is assessment? What is the difference? Why are evaluations necessary? You're evaluating the participants who are not up for reassessment, but need to be back in center in a congregate setting. And I like to use the evaluations as prepping me for when the participants are due for reassessment. So at our center, for example, we are evaluating the participants who we identified could benefit from coming back to in-center services. And we are updating the boxes 13 and 14 for our own records. And this way, we know when they are at the center or at home, what services they will be provided, who will be providing those services. So this could look simply, like I said, updating their care plans, which is boxes 13 and 14. For example, we wouldn't be submitting this to the managed care plans. We would just be using it for our own needs. And for the participants whose TARs are due, full reassessments will be done, which includes completing the entire IPC using all of the MDT members and submitting the IPC to the managed care plans for approval. Next slide, please. So digging a little bit deeper with the evaluation, again, this is a less formal version of a full reassessment because you aren't needing to submit this to the managed care plans. This is for your own in-house records that would highlight the services that are being provided to the participant. Ideally, evaluating a participant in the center in person would be the most beneficial because you are evaluating their readiness for congregate services coming back to in-center services. However, there will be participants who might need those the evaluation to be at the home, and if that requires sending the RN, the social worker, the OT and the PT, if they are also doing their evaluations to the participant's home, that can be arranged. Otherwise, I found that for participants who are not ready to be evaluated or even reassessments in person, we are doing evaluations during routine calls and starting the conversation if there was any changes since the participant was at the center last year, which I'm sure all participants have had drastic changes within the past over a year now that we've been operating under TASK. What are the participants and families concerned about returning to the center? I think this is one of the biggest questions we can ask them. Is there anything more that we can do? What is your readiness? What are you most worried about? How can we help ease this transition as you come back into the center? Needing for strengthening, reconditioning, fall risk mitigation, change in need for medication administration, participants and families' readiness to return to in-center services. Transportation is probably the biggest one that we face. Not only is that a question that our families have, it's questions that centers also have, myself included. Like I said, right now we are using the participants' family members to bring participants in on an individual basis to be evaluated and reassessed, but we need to start looking at how we can go back to transportation services before the public health emergency. And another thing about evaluation, and which sets it apart from a full reassessment, an evaluation does not change the TAR dates. You are evaluating the participants who are not yet due for a reassessment. Their TARs are not expiring. They are still within their TAR period, but in order for them to come back for in-center congregate services, they do need to be evaluated. And that's the method you would use, a more informal process where the TARs will not change. You're not submitting to the managed care plans. You are just updating your records, your documentation in order for you to understand the services that you will be providing. This could even be in a form of a progress note, or like we're doing boxes 13 and 14. Next slide, please. Care planning during hybrid transition. The main points for care planning, again, have not changed. The care planning cycle has not changed. The setting of which the services will be provided might be different as we transition coming back to in-center congregate services, but remembering that we are still operating in a task model. And so we want to make sure that during a hybrid care planning, we are still stating the problem. Keep it clear, short, so that it gets to the point. State the intervention and who will be providing the services, the interventions. State the frequency, whether it's concrete or PRN, but you're wanting to try to be as concrete as possible. It will be difficult, but I feel that in our center, for example, the more we reassess, and as the months pass, it becomes a little bit more clear what we're doing, when we will be back in center congregate services, how often can participants come in, and that's all person-centered. It will look different for each participant based on their readiness to return to in-center services. When I say be as concrete as possible, what I'm saying, identify, is that intervention going to be provided once a week at the center, 2 times a week at the center, once a month at the center, etc., or how many times a week will it be at home? You're trying to do that. If you cannot, then you can always say when at the center, when at home, and you will see this in the examples that we share a little bit later. And lastly, you want to state a clear and measurable, attainable goal, so that when you are reflecting back 6 months later for reassessment, or even during the quarterlies, you're thinking about, were these goals met? Do I need to amend these goals as we move forward? For boxes 15 and 16, we're slowly going back to how we used to use boxes 15 and 16. So what they're meant for is to share information that is nowhere, it cannot be found anywhere else in the IPC. And I'll get into this a little bit later as I share my example, which is actually the next slide. But you want to talk about things that aren't in the IPC. So for example, vaccination status, new diagnoses, new medications, MMSE, GDS scores. And these are things that I found are good to have for our center. Sometimes the managed care plans might ask for that, or during surveys, CDA likes to see that. And so I found that boxes 15 and 16 are the best place to put that information to highlight where they can't find it anywhere else in the IPC. Next slide, please. And this is where we get into the examples of hybrid care planning. So this is an example of a care plan that we are using at our center. So as you can see, we are identifying the problem, and we are also mentioning the interventions. One thing I want to highlight, I went ahead and with our team, we decided that the best way for our center is to identify clearly the services, the interventions that will be provided in the center and the interventions that will be provided remotely. There will be repetition, as you can see. For example, in the center, it checks fasting blood glucose and notify the MD when they're out of the parameters, recheck if necessary, if again out of the parameters, provide rest periods, and then foot skin check. Now at home, we are clearly identifying that the participant and or the caregiver will check the fasting blood glucose at home and report it to the center nurse. And then number 7, center nurse will notify the MD if out of the parameters, and then instruct the participant or the caregiver to provide rest periods. Now for the frequencies, again, it's each day that the participant will be at the center. Now we haven't started bringing participants back into the center in a congregate setting. That's why my frequencies are not as concrete as I'd like for them to be. But what I anticipate happening is as we go through TAR periods, the frequencies will become more and more concrete. So again, it's person-centered based on not only where the participant is at, but where the center is at as well. Are we already operating in a congregate setting? Are we bringing participants in? Is that particular participant ready to come back? How often? And that's where the evaluation and the reassessment come into play. And lastly, the goal. We want to make sure that it's measurable and attainable. And at the bottom here is an example of box 15, a little template that I created for myself so that I'm not missing information. This is information that I've identified that cannot be found anywhere else in the IPC, but relevant for each individual participant. So I just put a little disclaimer at the top for managed care plans when they're reviewing the IPC, that the entire IPC along with boxes 13 and 14 have been updated. Boxes 13 and 14 reflect in-center services as well as remote services during this transition phase. And then I put that as of this date, participant will receive services blank times a week in the center and blank times a week remotely. These frequencies are tentative and subject to change based on the participant's current needs. And I also added relevant information not found in IPC, so I'm including the vaccination status here. I'm including GDS, MMSE, GAD-7 scores. I'm including any communication that was sent to the PCP, any communication with the MDT, and any other findings or scores from screening tools. New diagnoses, like I said, new medications would all be included here. And I'd like to pass it on to Kay. She will be sharing an example that of another hybrid care plan, which looks a little bit different than mine.
Thank you, Lana. Hi, everybody, again. So this is an example that we have from AmeriCare CBAS, and I'll be presenting. Ours is actually very similar to this example that you'll see here that's been provided to us by Sarah from AmeriCare. What's a little bit different, as you can probably see from Lena's plan, is that rather than denoting what is provided in center versus what is provided remotely, all of those services are provided or indicated in the interventions column, as you can see, without separating it out exactly as this is in center and this is remote. Rather, the way we've conceived of interventions for the problems that our IPCs are capturing is that the modality of where the service is being provided is different, but ultimately the interventions are targeted towards the same problems in pursuit of achieving the same goals. So you'll see that in the interventions column, number 4, for example, says when at the center measure blood pressure, whereas on number 1, it says telephonically assess for signs and symptoms related to hypertension. So even though the place in which the service is being provided may be different, we're not really separating it out between what's being done in the center and what's being done remotely, which is a little bit different from what Lena has captured in their care plans. And part of the logic of why we chose to do it this way was in our minds, and what made sense for our center was to not think of in-center services and remote services as completely separate animals, but rather as different modalities, different ways in which to provide services under the CBAS task model. So rather than us trying to shift gears completely of going from one program into another, it's more of a fluid process in which we're just expanding what we're able to do on behalf of our participants in order to meet them where they are, which I think is a principle that's been carried forward for all of the presenters throughout all of these webinars, is that all of these changes are really in pursuit of being able to serve our participants in the safest way possible, in the most person-centered way possible. And so in our care plans, similar to the AmeriCare care plans, the problem statement and the goal statements have stayed relatively the same before COVID-19 as well as after, hopefully after COVID-19, because we're still assessing the participant based on whatever their needs are at that particular moment in time. These may have shifted, these may have changed because of the external factors and the other environmental conditions that have been wrought upon them by COVID-19, but ultimately the assessment process and the care plan that results from it is reflective of those assessed needs. And so when we denote that something will be provided in center, that's reflecting that this participant will now be coming into the center at least once a week, and possibly more as conditions change and our center is more and more ready and able to bring more people in through the congregate modality versus more in the remote modality. And so all of our documentation really flows from the care plan and the IPC. The IPC is always the pillar upon which all of the documentation within the center flows from. So we use this care plan as the basis for our progress notes, which we'll be using mostly for the time being, and possibly in the future as we move more into a congregate setting, where we'll be able to see our participants on a daily basis. We may move more into flow sheets. However, again, we've discussed this before. There's really no right answer in that you have to do flow sheets or you have to do progress notes. Whatever works best for the workflow that your center is most comfortable with is appropriate, as long as it captures what is being done within that care plan cycle that Lena outlined for us so clearly. And so for our center, for the time being, we're using these care plans as a continuation of all of the remote services and all of the really important information that we gleaned over the past year through the weekly COVID checks, through the doorstep checks, the in-person checks, and all of the assessments that have been done. We're just kind of adding on through more in-person in-center evaluations and assessments and congregate services to both confirm what we've been seeing through remote services, as well as make any changes as necessary through this additional modality. And I'll be passing it along to Amanda.
everybody. Okay, so just like everybody and how this is going along, the way that I conceived of it was a little bit different. We've got one care plan up here. This care plan is mostly for people who are receiving, so this care plan itself is only for while someone's in the center, right? So this actual care plan, not this person. This person's receiving services both at home and in the center. So if you also could take a look, so just so you know, this is one way to do it, and then also take a look at your handout that has like the hybrid care plan, hybrid risk for falls care plan will be the other one to take a look at as we go through this. And I talk about kind of my thought process as we went through. So my number one goal for care planning for our members, participants who are receiving services both in the center and at home was flexibility. So I didn't want my staff to have to write a care plan for 2 or 3 days that they're coming to the center, and then 2 days when they're not coming to the center, because my goal is that the days that they're in the center is going to increase over the next 6 months until they're at 5, 4, 3, whatever they're approved for per day at the center. And I didn't want my staff to have to keep updating it based on those changes of actual attendance. So I wanted to have like some real flexibility in that. So, and I believe, you know, we're going to have a lot more flexibility in opening up and providing more services and being able to transport more people. As Kay had mentioned, you know, or Len, I can't remember, I'm sorry, but it's important to realize that the problem, the goal of the care plans are not going to really change. Those are really going to stay the same. The differences are in the interventions and the frequencies that we're providing those services. So we created all new care plans for, or I should say we updated all of the care plans for our members who were coming back to the center in person. We did this so that at reassessment, we weren't, you know, one, because we needed to take care of the people. We needed to update our care plans because we needed to take care of the people in the center with what their needs were, as well as kind of update them for what we're serving at home. So if you look at kind of the care plan that's here on our, we will be using flow sheets. So what I really liked about how we were doing this as well is that it generates the flow sheet so we can track the services that we're providing. So the example for the hybrid personal care supervision one, you can see the flexibility here. So it's one at the center, 1 to 5 days a week. When transferring while at the center, 1 to 5 days a week. When ambulating at the center, 1 to 5 times a week. So that's really, we don't provide a lot of personal care in the home. So of course that one is going to be completely and you know, in-home or in-center kind of care plan. But if you look at the other one that you guys got sent, which was a hybrid risk for falls, and we look at some of the interventions, and I'll just read it because you guys may not be able to open it as quickly. But one thing that I wrote was provide supervision of the program aides and provision of assistance. So that's what I wrote there, was one receiving in-person services. So that's pretty clear that the supervision of the aide is only going to happen while they're in the center. But the second one I have there is the intervention is support Janie in decreasing risk for falls, enact fall prevention program. So that's one, you know, so that's reinforce 1 to 5 times a week during phone calls or in person when receiving services at the center. And the third one, promote Janie's sense of control over her own health, instruct to get up slowly, that kind of thing. The frequency on that is when for in-person services and on the phone during contact calls 1 to 5 times a week. So it really kind of describes what it is we're doing. So we're not, if one of my interventions is to provide support or to provide, you know, anything that's kind of in a verbal way or reinforcement, that can be done both in the center and also on the phone. So I want to make sure that, and again, because it's flexible, right? So we're going to have people who come to the center 2 days a week and are home 3 days a week, but then it's going to be 3 days a week and 2 days a week. So I really wanted to have that flexibility, and that's where the frequencies, I put most of that into the frequency piece of the care plan. And again, any way you do this is going to work as best as you can. My one goal for my staff is to tell them, just make sure it makes sense. So whatever you write, just make sure that it makes sense, that it reflects what we're doing and it makes sense. So I guess that's about it for that one. And I gave a bunch of samples for you to look at too. So we can go on to the next slide. So following up on participants who enrolled during TAS. So we actually enrolled quite a few people during TAS. The center, when I took it over, we took it over in February of 2020. So it was a great time to take over a brand new center. So they didn't have a lot of census. They didn't have a lot of people in the center at that time. So one of my goals was to make sure that we served more people in the community. So we did. So anybody who wants, so if I admitted somebody during TAS, and they want to come in for congregate services, we have to have TB clearance. So that's kind of bottom line. We always need TB clearance when someone's in the center. When somebody comes to the center, you may not have gotten TB clearance for them if you admit them during TAS. So be sure to get them. But make sure you ask about the last TB test they had. I mean, sorry, when they had their vaccine. They should wait 4 weeks until after the vaccine, after their second dose of the vaccine, or get it just before. And this is an interesting. This one for staff too. So when we want staff to be vaccinated and we want them to start, we ask them to get their TB test before. If they haven't been vaccinated, get their TB test before they're vaccinated. So then we don't have to wait, 4 weeks after that vaccination. Reassessments on participants enrolled during TAS are due on their regular renewal date. So if you admitted somebody in June, they're going to be due in December. If you admitted, I'm not going to run all the 6 months because that's too much math from my head. So they just need to be reassessed. We are doing remember to do some type of home visit as well, whether it's on the phone, asking questions over the phone, whether it's doing a porch visit and asking the family about their home and their home life, when you get a peek inside the house. Be sure that you do complete that home visit form as well, because it is important to make sure that our members are well taken care of and have what they need at home and their home is safe. Okay. Next slide.
Okay, thank you, everybody. We now have some time for questions. If I could invite our panelists to join us on screen. I've been making note of a few questions that have come in to ask y'all live. This is both for Adult Day and Adult Day Healthcare. Let's try to keep our answers as concise as possible so we can get through a number of these. So Terry, are you updating physician reports at this time as you start bringing more people in, and have you been doing that over time since September? And then I'll ask the same of Richard, I think.
Yes, we are. We're requiring them to have that completed, updated and completed.
Okay, great. Richard, how about you?
For us, yes, we're having H&Ps every reassessment cycle, just because it kind of is the basis for the medical side of what they need and kind of any differences. So it gives us a good starting point that the nursing can branch off from. And that includes everything from the medications to the diagnoses.
And Kay, are you also obtaining medical records from, let's say, people have been hospitalized or have had other major changes in condition? Are you gathering that data?
Yes, we have. As far as our medical records and documentation from other healthcare providers, inclusive of the H&P, that hasn't changed throughout the past year. We've continued to get all the medical records we could possibly get our hands on.
Lena, could you clarify the use of OT and PT and speech at this time for both reassessments and regular new assessments?
We've brought everyone back on board. Before bringing participants in for a congregate setting, we were only using RN, social worker, the program director, and outsourcing OT, PT to home health because we didn't have the proper PPE and the process to do in-home services or in-person. But now that we are bringing participants back in, we have brought on OT and PT as well to do full reassessments and hybrid care planning as we move forward. So we've trained everyone, even though they're contracted, we've trained them on how we want the care plans to look, what our mindset is, and we're moving forward with that.
And Lena, a follow-up question having to do with evaluations, the area that you covered today. Are you updating the care plan if there are significant changes, or making a progress note? How are you documenting the results of those evaluations as you're conducting them?
We are updating the care plans for our records. We find that that would be easier when the participant, it does come back for a TAR, for their TARs when they're renewed, that there will be an updated care plan already in place. Might need to tweak it just a little bit more, but we find that that's probably the best way and the easiest way to identify the services that need to be provided versus a progress note. You'd have to go through all progress notes to find that note. This way, we just think it's a quick find what we need to do when they're here.
We had somebody ask how you feel about PRN for interventions during this transitional period, or do you like being a little more concrete? Let's start with Kay on that one.
Yeah, I know I saw a lot of those questions, and I think the PRN as needed frequency is just a necessity of the time that we're in, because it's a transitional phase and we have to be flexible and fluid with how we care plan and plan for the frequency of interventions. It might be that even though we plan for our participants to start coming in to receive in-center congregate services once a week, that things happen, that the participant is unable to come, there may be limitations with transportation, and just to be make sure that you have a workable document that doesn't need to be changed every single time a participant comes in. I think that the PRN does allow for that flexibility while also providing structure for the team in order to monitor the participant and provide services safely.
Okay, the care plan examples we saw today did have some frequencies in them. So do others of you on the panel want to chime in on sort of frequency and PRN, Richard?
Yeah, we're taking a little bit of a different approach. I think when we insert PRN in the care plans that exist right now during the hybrid phase, we're not thinking about PRN in the traditional sense of as needed. It's kind of a combination of factors of that the participant can tolerate, that we can provide within the given circumstance. So I think we're defining PRN differently right now than we have before. So I don't think it's the same thing when we're kind of explaining that. But for us, we try not to use PRN, and we're trying to put in the frequencies as kind of goal markers in itself. So we'll put, for example, blood pressure gauge, measurements by the RN one time a week for doorstep services, but they might not always be able to do it once a week, right? But that's still a goal marker, kind of a baseline that we like to have. And so we're taking a little bit of different approach and trying as much as possible not to have PRN, so we can have markers that we can go back to when we return to full congregate services. But I think Kay's points are, exceptionally valid as well.
Lena?
For my example, I want to point out, I did say, for example, checking fast is where it says in center, checking fasting blood glucose. For the frequency, I put each day at the center. So right now, it's not clear how many times a day the participant will be at the center. That's why I put each day at the center. The PRNs that I've used, for example, is notify the MD if the blood glucose is out of the parameters. That's PRN. That's as needed. The recheck the blood sugar. That's PRN. If it's out of the parameters, then we would check the blood glucose again. So that's PRN as well. For example, the remote services, I put participant or caregiver checks fasting blood glucose at the home and reports it to the nurse. And for the frequency, I put each time nurse calls. So if I would want the viewers, the audience, to make sure that they really look at when we use the PRN, because it really is meant for, like Richard said, the traditional use of the word versus what else we put in there. I know right now with the fast glance, it looks like there's a lot of PRNs, but I try to be really specific with my care plan, for example, that I identify when at the center or when at home, because right now it's not clear the frequency that they will be at the center. And like I said, maybe in August, my reassessments are going to be much more clear. I'll know how many times a week participants will be coming in at the center and receiving services at home.
Great.
And if I
Okay.
could just add a little bit for the frequency. A lot of our frequencies as well, similar to what Lena was saying, it's 1 time a week and PRN, so that it really captures the original premise of TAS of doing at least that once a week assessment and COVID check. But anything additional is to follow up, is to be consistent with all of the additional things that you capture, the information that you do capture in that once a week check. So like Lena was saying, those PRNs are really there to help give you the structure and a basis upon which to have a set series of data that you can track in a more consistent fashion, rather than just it being all of your services are only as needed, which is not really the intention of what are the care plan examples that we've provided.
Okay, some sound advice there. Well, I know we're going to be talking about this more over the coming months. And each month will bring something new. It feels like every day brings something new. So let me stop here as we're getting to the close of our time. Thank every one of you for joining us today, sharing your wisdom, your thoughts, advice for others. And thanks to all of you who submitted questions. We tried to answer as many as we could on the fly, and some of them will follow up with you afterward. Resources, as always, quick clicks here, and then be sure you go back and look at the ADP ADHC slide for some additional resources on guidance. Next. Thanks, Pam. And I want to highlight a couple of important trainings that are coming up that are not web talks, but vitally important for your information. Department of Social Services, May 21. There's a registration link earlier in the slideshow. And CADS training, there's a clickable link here. COVID Return to Work Strategies, a legal perspective. Protect yourself by understanding all of the complications of getting people back to work in a way that makes sense for you all and keeps you compliant with the current laws and rules. And upcoming web talks, we're very excited to be continuing to chat with you about person-centered TARS. Really excited about the psychology of reentry and what that means for your participants, staff, caregivers, anyone who is working in your world right now. Just a lot to dig into there. So we're very excited about that. And then we hope that we'll be able to plan something for July, right now, tentatively the 7th, working with your managed care plans for intakes, transfers, and discharges. So those are some upcoming dates you'll want to circle on your calendar. Next.
And Lydia, if I can correct, our CADS training is May 24th. Sorry for not catching that earlier. So it's Monday, May 24th.
Oh, I apologize for that. That was a quick entry this morning before we posted. Thank you, Pam. So the 24th. Just go on the CADS website and you'll see the registration materials there. That link is correct. A thought for the week, as always, Carl Rogers, one of my favorites, being an old psychology major from way back when. This is an expression of person-centeredness. Carl Rogers was a humanistic psychologist who was the antidote to B.F. Skinner and behaviorists at the time back in the 60s. So I love this quote because it talks about what you all are doing. It's the client who knows what hurts, what directions to go, what problems are crucial, what experiences have been buried. And that's what you're all about right now for your participants and also for yourselves who have also been through a pretty traumatic year together. So I think this talks to us about empathy, understanding, support, and we're all here to support each and every one of us through these web talks and through your work every day. And feel free to lean on any one of us, any of the panelists, vision team members, myself, Pam, for any questions and support that you might need to continue your work, everyone. So please stay safe, be well, carry on, and we'll see you in a couple of weeks. Take care.